Hi, I'm John Piccini. I'm a cardiac electrophysiologist at Duke University and the Duke Clinical Research Institute. Post-operative atrial fibrillation is a significant problem in clinical practice. Approximately between 30 and 60% of patients who undergo cardiac surgery develop atrial fibrillation following their cardiac surgery. And despite lots of advances in both medical therapy and surgical techniques, the incidence of this problem has really been unchanged for decades. And I think, many of us think that there are a lot of treatments available for the prevention of postoperative AFib, but there are actually a limited number of therapies that are both safe and effective. If we think about beta blockers, that they have a class 1 indication for the prevention of postoperative atrial fibrillation. But as many as a third of patients don't receive beta blockers, and even more have them withdrawn after surgery. So there's an unmet clinical need for therapies that can prevent postoperative atrial fibrillation. And we know that the autonomic nervous system is very important in the initiation of arrhythmias, including postoperative atrial fibrillation. And botulinum toxin, which is a compound many are familiar with. A lot of folks don't connect it to the heart or cardiac therapies, but there have actually been some early studies that demonstrated in patients undergoing bypass surgery, application of botulinum toxin to the epicardial fat pads impairs cholinergic transmission within the ganglionated plexi of the heart, and may suppress atrial fibrillation following cardiac surgery. So that was the background and the rationale for the phase 2 dose-ranging NOVA trial. Yeah, so again, we hypothesized in the trial that botulinum toxin type A can reduce the occurrence of atrial fibrillation after cardiac surgery. And the proposed mechanism is that botulinum toxin impairs cholinergic transmission at the nerve terminals in the ganglionated plexi, and this reduces parasympathetic stimulation and potentially may also impact sympathetic signaling within the heart. But we know that parasympathetic stimulation shortens the atrial effective refractory period and increases dispersion of repolarization. And those are important changes that are implicated in the development of atrial fibrillation. And so suppressing that parasympathetic input has the opportunity to prevent atrial fibrillation. Yeah, so we were looking at patients who were aged 55 to 90 years, who needed or who were scheduled to undergo cardiac surgery, who were in sinus rhythm in the 48 hours before the surgery and did not have any contraindications to botulinum toxin, but also were patients that didn't have a profound risk of perioperative mortality. So if a patient had a Euroscore that predicted a perioperative mortality of more than 7%, those patients were excluded. And we randomized those patients to one of 3 treatments: sham placebo injection of 25 units in the 5 epicardial fat pads, or injection of 50 units of botulinum toxin type A into the 5 epicardial fat pads, or said differently, placebo versus a total dose of 125 units versus a total dose of 250 units. Those patients underwent 30 days of telemetry, both inpatient and then outpatient. And the primary endpoint was the occurrence of sustained atrial fibrillation of 30 seconds or more during that 30-day period. Yeah, so what we saw was in the overall population, which included patients who had both bypass surgery, valve surgery, and combined surgery, we saw no difference in the primary endpoint of 30 seconds of atrial fibrillation. However, when we looked at our pre-specified subgroups of patients undergoing isolated bypass surgery, we saw a trend to reduced amounts of atrial fibrillation, including a statistically significant reduction in longer periods of atrial fibrillation. And in the pre-specified subgroup of patients 65 years of age and older, and we know that older patients are at higher risk for atrial fibrillation, we saw statistically significant reductions with the 125 unit dose of botulinum toxin. If we step outside those primary and secondary endpoints, we didn't see any differences in length of stay. But interestingly, when we looked at rehospitalization within 30 days, there were lower rates of rehospitalization in patients who were treated with botulinum toxin compared to placebo. And you might ask, well, what were the causes of those rehospitalizations? The majority of them were for cardiopulmonary reasons, so lower rates of cardiopulmonary rehospitalization. And then with respect to safety, because when you're injecting neurotoxin into the heart, you obviously want to make sure it's safe. We saw no difference between placebo and botulinum toxin A for any safety endpoint, including adverse events, serious adverse events, or treatment emergent cardiovascular adverse events. There was also a dedicated study of pulmonary function testing, and it showed no difference between those treated with placebo versus botulinum toxin. Clinical trialists will often say one trial is one trial. So I think there's findings from NOVA, and then I think there are findings when we put all the trials together. So to be clear, in this phase 2 exploratory dose ranging study, we did not identify statistically significant reductions in the primary endpoint of 30 seconds of atrial fibrillation with either dose compared with placebo. We did see suggestion of benefit in patients undergoing isolated bypass surgery and in patients 65 years of age and older who were treated with 125 units of botulinum toxin type A. And if we look at other trials, the trials that have been positive with injection of botulinum toxin or calcium chloride into the ganglionic plexi, were positive in patients who are undergoing bypass surgery. So that may be a population that merits further study. The other important take-home messages is, interestingly, we saw that botulinum toxin was associated with lower levels of inflammatory biomarkers between postoperative days 2 and 4. So from a mechanistic standpoint, the findings of NOVA corroborate a lot of preclinical experiments which have shown that these types of interventions may be beneficial not only due to the direct autonomic effects, but also due to decreased degrees of inflammation through secondary autonomic mediated mechanisms. Yeah, so, I think it's important to realize this was a phase 2 study. So it actually had fairly low power. We had 80% power to detect a difference of 20% absolute risk reduction or 40% relative risk reduction. That's obviously a very high bar. We didn't have power to discern all clinically relevant differences in the amount of AFib, nor did we have power to discern differences in cardiovascular outcomes. So again, if I step back and look at all the trials that have been done, CAP-AF, TNT, the Pokushalov study conducted in Russia in patients with prior AFib and bypass surgery, I think it is still not clear whether botulinum toxin can effectively prevent postoperative atrial fibrillation. And it appears that the patient population that has the most promise for a treatment effect are those patients undergoing bypass surgery alone without valve surgery, or patients who are 65 years in age and older. And I think obviously we need additional clinical trials to answer those questions.